Welcome, guys. Um, in today's session, we'll be discussing about vasculitis. The plural of vasculitis is vasculitis. So I might make that term. We'll classify. We look how vasculitis, various forms of vasculitis are classified, but we discuss one form of vasculitis which affects the large vessels, known as giant cell arteritis or the temporal arteritis. Welcome, my name is Wallace Mugeni, and I'm the reductor. So, what is vasculitis? Simple, very simple. Simply refers to vessel wall inflammation. The vessel wall has three layers: tunica intima, media, tunica adventitia. Now, when any of those layers is inflamed, that will be vasculitis. Now, the two most common pathogenetic mechanisms are either immune-mediated inflammation or direct vascular invasion by infectious pathogens. So it can be, when it is immune-mediated, we can simply define it as non-infectious vasculitis. When it is mediated by infectious pathogens, that will be infectious vasculitis, okay? And there is need for you as a clinician to distinguish the two, because when it comes to therapy, immunosuppressants such as corticosteroids can be administered for the immune-mediated inflammation, and the prognosis will be very good. But if you use immunosuppressants and the vasculitis is due to an infectious pathogen, the vasculitis, in fact, will be exacerbated, so the symptoms will worsen. So you need to distinguish, okay? So classification of this. Now, vasculitis can be classified on various bases. Now, either one, on the size of the vessel wall; two, on the type of inflammation. These two are, we will discuss these two majorly, but also you can use presence of specific autoantibodies. Also, you can use organ specificity. Where is this vasculitis mostly occurring? Also, you can use the role of immune complexes. So let me in this session, we'll be discussing non-infectious vasculitis. So I told you vasculitis can be either immune-mediated or due to direct invasion of infectious pathogens. But also these infectious pathogens can cause vasculitis indirectly by either they can cause an immune complex formations or they can also lead to cross-reactivity. So some antibodies directed towards the infectious pathogens can cross-react with the vessel wall. So even the infectious vasculitis can indirectly cause, the infectious pathogens can indirectly cause vasculitis. Now, under non-infectious vasculitis, the main immunological mechanisms include one, immune complex deposition, okay? And under this, I want you to remember one, especially one, polyarteritis nodosa, okay? Where in a third of cases, only a third, we have immune complex. Also, drug hypersensitivity vasculitis is due to immune complex deposition. Also, you have anti-neutrophilic cytoplasmic antibodies, okay? And these are mainly of two types. The ANCAs, you will find these known as p-ANCA ANCAs. We have of two types, c-ANCA or cytoplasmic ANCA and perinuclear ANCA. So c-ANCA and p-ANCA. So the other name of c-ANCA under the new Robbins 10th edition, it is also known as the PR3. PR3. So antiproteinase 3, antineutrophilic cytoplasmic antibodies. Then the perinuclear is known as anti-myeloperoxidase, MPO, antineutrophilic cytoplasmic antibodies. So please remember that. Now, c-ANCA is implicated in the Wagner granulomatosis, or also known as the granulomatosis with polyangiitis. p-ANCA is involved in the microscopic polyangiitis and microscopic polyangiitis and the Churg-Strauss syndrome. Yeah, Churg-Strauss syndrome. Now, anti-endothelial cell antibodies are involved in one of the diseases which is known to cause childhood myocardial infarction, known as Kawasaki's disease. Okay, please remember Kawasaki's disease. And how do you treat Kawasaki's disease? A very controversial way. You use aspirin in children, and that is controversial. Okay, so then autoreactive T cells are implicated mainly in the one which we'll be looking at today, the giant cell arteritis. Now, here you can see on the basis of pathogenesis can be due to it can be infectious vasculitis due to a bacteria, rickettsia, fungus, virus, or spirochetes. Can be immunologic, where you have immune complex mediated, and here you have HSP, SLE, also cryoglobulin vasculitis. Also, in a third of cases of PAN, in a third of cases, we have immune complex due to hepatitis B virus. Then ANCA, the anti-neutrophil cytoplasmic antibodies, we have Wagner granulomatosis, or which is now known as granulomatosis with polyangiitis. Here we have c-ANCA. Then the Churg-Strauss syndrome and microscopic polyangiitis, we have the p-ANCA. Now, you have direct antibody-mediated Goodpasture syndrome, and also now Kawasaki's disease. Here we have anti-endothelial antibodies. It can be also cell-mediated in organ rejection and in inflammatory bowel disease. Now, although these previously they were unknown, evidence suggests that giant cell arteritis is due to it is T-cell mediated. Takayasu is autoimmune. In a third of cases of polyarteritis nodosa is immune complex mediated, with HBV being implicated, hepatitis B virus. In the two thirds, the etiology remains unknown. Now, on the basis of vessel, size of the vessel, they can be either be large vessel vasculitis, medium vessel vasculitis, or small vessel vasculitis. Now, and this is how they go. Very easy. Large vessel vasculitis are two: temporal arteritis and Takayasu arteritis. The other name of temporal arteritis is giant cell arteritis. Now, under small vessel vasculitis, they can be either ANCA associated or non-ANCA associated. Now, under ANCA associated, I told you this, you have p-ANCA, which is now also known as the MPO, myroperoxidase, anti-myroperoxidase ANCA, okay? And c-ANCA. Now, under p-ANCA, it is microscopic polyangiitis and the Churg-Strauss vasculitis. Under c-ANCA, it is the Wagner granulomatosis, which is now known as granulomatosis with polyangiitis. Under non-ANCA, we have hypersensitivity vasculitis, okay? The HS papilla, the Henoch-Schönlein papilla, that is, then they have the Beckett's syndrome. And under now this medium vessel, let's go back. Under the medium vessel, we have polyarteritis nodosa, okay? In a third of cases is immune complex mediated. Then you have Kawasaki's disease. Then you have Vargas disease, which is known as also known as the thromboangiitis obliterans, or obliterative thromboangiitis. Now, based on the type of inflammation, you can classify either the vasculitis with the granulomatous inflammation or a vasculitis with necrotizing inflammation. Now, those with granulomatous inflammation include giant cell arteritis and Takayasu's disease. These both are large vessels, so that is easy to remember. Then Wagner's granulomatosis and Churg-Strauss syndrome. Wagner's, remember I told you, the ANCAs associated, the anti-neutrophilic cytoplasmic antibodies associated are the c-ANCA, or the c-ANCA. The other name of the c-ANCA is PR3, the antiproteinase 3 anti-neutrophil cytoplasmic antibodies. Then you have Churg-Strauss syndrome. The antibodies implicated here are the p-ANCA, okay, or the MPO. Then with necrotizing inflammation, polyarteritis nodosa will be there, Churg-Strauss will also be there, Wagner granulomatosis is there, and microscopic polyangiitis. Now, I want you to note that Wagner granulomatosis, or it is now also known as granulomatosis with polyangiitis, and Churg-Strauss syndrome are in they display both types of inflammation. So Wagner and Chagstras syndrome, Wagner's granulomatosis and Chagstras syndrome, they display both granulomatous and necrotizing inflammation, but the predominant form of inflammation will be granulomatous. Okay, so granulomatous is predominant in these two, but they also show necrotizing inflammation. Now, let's look at giant cell or temporal arteritis. Now, it is a chronic inflammatory disorder, okay, which displays granulomatous inflammation, and it typically affects large to small sized arteries of the head, okay? Now, why is it also known as temporal arteritis? It is not linked to temporal arteritis because the superficial temporal artery is more vulnerable to being inflamed. Rather, it is named so because when you want to carry out a diagnosis of this disease, the biopsy you will obtain it from the superficial temporal artery. So that is why it is named also named as temporal arteritis. Now, also vertebral and ophthalmic arteries can also be involved. Also, they can involve the aorta, and in this case, it will be known as giant cell aortitis. Okay. So why should you carry out a prompt diagnosis and treatment? Now, there is need to carry out a prompt diagnosis and treatment because it can involve the ophthalmic artery, and once the ophthalmic artery is involved, it can lead to sudden total blindness, okay? And it is the most common form of vasculitis occurring among older adults in developed countries. So mainly it is a disease of people above the age of 50. Rarely will you find it below the age of 50. Now, let's look at pathogenesis. It is T-cell mediated. It is thought to be a T-cell mediated immune response to a vessel wall antigen which hasn't yet been characterized. Now, pro-inflammatory cytokines, especially tumor necrosis factor and anti-endothelial cell antibodies also contribute. Now, the characteristic granulomatous inflammation why do we say that it is immune mediated? Because there is a granulomatous inflammation, okay? Then it is associated with certain major histocompatibility complex class 2 haplotypes, MHC class 2 haplotypes, and has an excellent therapeutic response to steroids, the immunosuppressant. So that is why we say it is it is not to be immune mediated. Okay. Now, the predilection for vessels of the head remains yet unexplained. Okay, so this giant cell arteritis mainly affects the vessels of the head, but we don't know exactly why, but there is a hypothesis that those vessels of the head usually develop from a distinct antigen, and therefore they may express unique set of antigens, and these antigens are the ones against which now the T cells are directed against. Okay. Now, let's look at the morphology. How we need to present the morphology. Now, the changes are notoriously patchy. Okay, so it is patchy, so it will not occur along the entire length, so it will occur in patches. Okay, and the involved arterial segments will exhibit nodular intimal thickening. It's not that, so it is segmental nodular intimal thickening. Okay, and there will be occasional thrombus, and this will reduce the vessel diameter and cause distal ischemia. Now, a vast majority will exhibit granulomatous inflammation within the inner media, centered on the internal elastic membrane. Then there is also an infiltrate of lymphocytes, macrophages, and some macrophages fuse to form multinucleate giant cells. Okay, and also there will be fragmentation of the internal elastic lamina. Please note that fragmentation of the internal elastic lamina. Now that occurs in 75% of the cases. Now 25%, the granulomas and giant cells are absent, and the lesions will exhibit non-specific p-ANCA. So it is an inflammation involving the whole vessel length, the vessel length, or the vessel length, all of it is involved. So it is spanning across the vessel length. So p-ANCA, and with a mixed infiltrate of acute and chronic inflammation. So you will see an infiltrate of neutrophils, lymphocytes, macrophages. Okay. So now healing in this case is marked by intimal thickening, okay, with medial thinning. So there will be medial attenuation and scarring and adventitious fibrosis. Now, in this type of vasculitis, different stages of development will be seen within the same artery. So you can meet this is the same artery, so it is patchy. So here you will find a region and another region here. So these regions don't need to be at the same stage. They can be at different stages. Now, let's here you can see the superficial temporal artery is the most is the one which is involved in this case. So and it will be painful on when you palpate it. It is painful, and when you take a biopsy of that, this is what you expect to see. Okay, here you can see in black here is the internal elastic membrane. Okay, this is the internal elastic membrane. So here you can see it is fragmented. So there is fragmentation of the internal elastic membrane. Then here you can see medial thinning or medial attenuation and scarring. So deposition of the fibrous tissue. And on the H and E, you can see a giant cell here. Okay, so this, and here you can see there is occlusion of the lumen. So there'll be a distal ischemia. Okay, so this is what you expect to see when you take a biopsy of the affected vessel. Now, how will it present clinically? Most of the symptoms are non-specific, okay, and they include fever, fatigue, anorexia, and weight loss. Now, which is the most common? They will ask you this. Which is the most common vasculitis-related symptom in giant cell arteritis? A headache. Okay, a headache. It is the most common. Now, which is the most specific? Jaw claudication. So a patient will come and tell you when I eat. So the patient comes to you. He or she is old, but by the way, I forgot to tell you this, that it mainly affects females. So maybe she comes to you and tells you, when I chew food, I'm experiencing jaw pain. So you want to suspect jaw claudication, giant cell arteritis. Now, visual symptoms may occur, and they can range from diplopia to sudden blindness. Also, flu-like symptoms with joint and muscle pain, the polymyalgia rheumatica present, and ESR is elevated. The erythrocyte sedimentation rate is elevated, so showing that there is an active inflammation. So I think that was that, and it was very easy, and I hope you enjoyed, and thank you for attention, and follow for more med content. Thank you very much.